Hello and welcome to the Pavilloneer podcast, where we explore the ever-evolving frontier of substance use disorder, treatment, and recovery. Today we have Trina Fullard, Bayha, and Brian Coon to help us explore tobacco cessation. Trina is a certified clinical supervisor and licensed clinical addiction specialist with over 20 years experience in the field of substance abuse nonprofit programs. She currently serves as the Chief Program Officer at Charlotte Rescue Mission. Kim has more than 30 years experience managing public health education and prevention programs in community, healthcare, and school settings. Her area of focus is health promotion with expertise in tobacco prevention and control. Kim currently serves as the Tobacco Control Manager for Mecklenburg County. And Brian is a licensed clinical addiction specialist, certified clinical supervisor, and nationally credentialed as a master addiction counselor. Brian came to Pavillon in 2008 and currently serves as the Chief Clinical Officer. Want to welcome Trina, Kim, and Brian. Thanks for being with me today. Let's just sort of go around our little Brady Bunch squares of smiling faces. And if you could just introduce what got you into this field and what about the tobacco nicotine piece of this field are you most passionate about?
I got into addiction treatment during graduate school, my internship back in 1988. Addiction treatment's all I've ever done, really, in addition to co-occurring mental health disorders. But just attracted to the work and the joy of watching people make big changes in their life. It's super rewarding. And I think my involvement in tobacco-free addiction treatment started when Pavillon underwent its change process. I was assigned to help guide that process. So I got into the tobacco-free part more as an assignment than something I chose on my own. And I've learned a lot from that, actually. It's been a great thing.
Well, I've been working in tobacco prevention and control for, over 20 years now. And I have kind of a lifelong career in public health. And when you look at chronic disease prevention, working in the tobacco control space is incredibly impactful, because tobacco use drives the majority of chronic disease in our community. And so tobacco control is a core part of public health. And I'll have to say that I had an aha moment back in 2014 when I went to a statewide Breathe Easy NC conference and learned about the incredible tobacco disparities within the behavioral health population. And that's when I walked away thinking, oh my goodness, this is an area, this is a population that has been left behind, and we really, really need to do something. And I committed to figuring out how locally in the Charlotte and Mecklenburg area to start addressing and bringing tobacco prevention and control to that population. And it's taken off from there.
Well, thanks for having me. And I will say that I went into the addiction field not by choice, but I feel like the field chose me. Having some family members who I could not help as a child and as a teenager and as a young adult led me into the field over 20 years ago. And my passion at that time was working with teenagers, trying to help them make better choices as a young person so they wouldn't become an adult and continuing to struggle with substance use disorders in general. So leading into the tobacco-free area, again, similar to Brian, I was working at a facility prior to my time here at Charlotte Rescue Mission, and was assigned to be a part of the committee that was starting the push of residential programs moving into the tobacco-free space. And so I became familiar with it. I was engaged with it. And then when I moved to Charlotte Rescue Mission, I was pleased to know that they had just scratched the surface of really making the commitment to be able to do that. And so we have made that turn and have been tobacco free for the last few years. And so it is the right thing to do. And once we got over that hump of some of the fears that I'm sure we'll cover later today, our agency is breathing easier, if you will.
I love it. Yeah, breathing easier. And it is the right thing to do. When I heard that, it struck me. I think in order to really dive into the depth and weight behind the truth of that statement, we might want to start with the harms of use and even secondhand smoke. So I'm just gonna lob that volleyball up to the three of you and see what comes out.
One thing that comes to mind for me right away, anytime this topic comes up, if I'm talking with colleagues like Kim or Trina together, or out on the road giving a presentation or a lecture for patients, doesn't matter. Whenever I think about that, Reed, I think about one statistic that really, really gripped me hard the first time I heard it. And I don't have the precise numbers. It's not the point of the exact numbers. It's the magnitude of the reality. The way I heard it put was the total number of deaths from all three waves of the opioid epidemic from 1998 through, I think it's 2018, is the number that die from tobacco in this country every year. And when I saw that presented, it had the exact numbers. But you see, the point is the size of the problem, and that the well-being of people is the most important thing. And secondhand smoke comes along with that there are people all around us. So when we get better, others are around us and benefit tremendously when one person recovers. And the same is true when one person is smoking. It's others are also brought into harms.
Well, and I'll add, bringing in that public health lens, what that number is, Brian, is 480,000 people a year just in the United States die from tobacco use, and that's deaths. For every death, there are 30 more people whose quality of life is impacted because of stroke or heart disease, cancer, COPD, and all these just devastating chronic diseases. And so I think we have become immune to tobacco because it is a quote unquote legal drug. It's something we've been talking about for, over 60 plus, 100 years. And so we've become immune to the dangers of it. If there were any other product that kills 50% of its users, it wouldn't be allowed to be on the market, right? But for a lot of complicated reasons, and maybe this is one thing that keeps me involved in tobacco control, is because not only is it about health, but there are social issues, political issues, agricultural issues, all these different issues that come into play with tobacco control. But bottom line is, we have to remember it is still the leading preventable cause of death and disease in our community. And so if we don't address it, then we're not doing our jobs in health and in wellness. And then when you look at those with either a mental health condition or battling substance use disorder, that some studies show that 50% of that population, they're not dying from their addiction or their mental health condition. They're dying from chronic disease from tobacco use.
Yeah.
And I mean, that just blows me away, the impact that tobacco has on health. Right.
Yeah. The thing for me, and Kim said it, is that it's preventable.
Mm-hmm.
You know, like it's preventable. And when we talk about secondhand smoke, there's no safe level of secondhand smoke that is, oh, if I'm only in a room for just a short period of time, you know, once a month, it's not that bad. Yes, it is. It's always that bad. And it always has that impact of affecting your lungs and affecting your heart and those things. And so the preventable nature of it, despite, you know, as Kim was saying, is that it's legal, the harmful effects are there from day one.
And everybody has the right to breathe clean air. And so, as Brian and Trina both pointed out, the harms of secondhand smoke. So we can't negate the importance of tobacco-free environments in eliminating that exposure to secondhand smoke. And another thing a lot of people don't know about is third-hand smoke. Secondhand smoke is that smoke you see in the air when a primary person is smoking. Third-hand smoke, when that smoke, you think that smoke has left the room or the car, the space, there are chemicals in it, heavy chemicals in it, that fall to the ground, and they cling on carpets, couches, drapes, car seat. And those chemicals, those third-hand chemicals, stay in the environment, and they interact with other chemicals and emit toxins into the air. So if you go into a space and it smells stale and yucky, even though somebody's not actively smoking, but you know somebody was smoking, that you're smelling third-hand smoke particles.
The most popular place that I think I have experienced that, Kim, is when you go into a hotel room.
Oh, yes.
I have actually gone into a hotel room and turned around and gone back to the desk and said, give me another room, because even though this is a non-smoking hotel, somebody's been smoking in this room.
Right. And there are toxins still in the room. And that's especially harmful for like babies, toddlers, pets. If you think about what they do, they're putting their little faces, you know, on the carpet, on the couch, on the bed, and they're breathing in those chemicals.
So Kim, you said everyone has a right to breathe clean air. Correct?
Correct.
I'm curious about the argument that everyone has a right to breathe dirty air. Everyone has a right to smoke if they want to smoke. So want to toss that up and see, where does that right, what are the boundaries of exercising that right?
Well, you know, smoking is not a protected class. It's not a protected behavior. That is not legally. You don't have the right to smoke. And as some people say, you know, your right ends where my nose begins, because, you know, as soon as you, if your behavior is impacting those around you, then, you know, you don't have a right to smoke. We all have the right, and we lead with equity. We lead with giving, you know, health equity is everybody having the right to live a healthy life, the best chance to live a healthy life, and to, you know, secondhand smoke does not have a place in that. And so
Yeah. I'll say for us, and, you know, being in a residential facility, and advertising on our website and in our admission conversations with folks who ask about whether or not they can smoke in our facility, and we tell them no, we're a tobacco-free campus. Well, they'll say, well, smoking is legal. And we address it very simply. We say, if you give us the consent to treat you, you will be in compliance with our rules, which state we're a tobacco-free facility. And so you have the choice to either come to do treatment with us or not. And it's that cut and dry for us. Doesn't make it easy, because we always have folks who want to challenge that, but we toe that line. And I second what Kim is saying about, there's not a right to smoke, right? We have clean air. The pollutants in the air are just that. They're pollutants. And so just like any other, behavior, if I'm driving down the street and I'm driving erratically and I'm weaving and bobbing and weaving and I'm impacting myself, that's one thing. But the minute that I ram into someone else's car, I've impacted that other person, and there are consequences of that action.
Reed, anytime I think about the statement, which whenever I hear it, it's presented to me personally as a challenge rather than just a true statement about law. There's a right to smoke, or within the bounds of law, I can smoke, that sort of thing. I always think as a clinician does, which is to say to myself, usually not out loud to the person, that if it in fact is true, you have a right to smoke. I always want to complicate that by puzzling over things like cravings and withdrawal and other things that someone who's more or less a smoker or has some criteria of tobacco use disorder or something like that, that I wonder what it means when we say we have a right to smoke, when I'm not super in charge of whether I have cravings or not, or whether I have withdrawal or not, or whether the puff of a cigarette brings me back to some kind of level playing field and I don't feel distressed by not smoking. So in that way, I think about what it even means to have a right to smoke when it's expressed by someone with a use disorder, and is not, maybe really experiencing the right to smoke, but the drive to do it,
Right.
versus the freedom to do it. But I also love the thought that, Kim and Trina have expressed, which is that one's right to smoke maybe ends at the space of the next person, so their right to not smoke. And the whole idea of tobacco-free treatment is simple, which is that the space is a safe place. It's literally tobacco-free. And that means not doing harm and not having others bring harms. It's pretty simple in that way.
Brian, is Pavillon as cut and dry with its approach to the person seeking treatment as what we heard from Trina with the Charlotte Rescue Mission?
Our approach initially, we went tobacco free in early 2013, and our approach initially was fearful and unsteady and a little bit apologetic, I think, outwardly to prospective patients and their family members, even referral sources. And I'm sort of summarizing it, but it was some version of, is it okay that we're tobacco free, and sort of very timid in a lot of ways for a lot of reasons. And we had an outside consultant finally come and figure that out. We didn't even realize we were taking that posture, and they turned us the other way. And it's, hey, if you come, these things are going to get better and you'll be tobacco free as well. It's a very positive message. It's a very encouraging thing to get completely well and put the tobacco use behind you. And as Kim outlined previously, those disorders that come along with it. So it's a positive message because it's a positive way of conducting treatment. It's nothing to apologize about.
One thing that I'd like to add is that whenever we talk about tobacco control, we do it. It's important to approach it with compassion, and recognizing that tobacco use is a devastating addiction, and it's one of the most. It's a wicked addiction. One of the most addictive drugs there is, nicotine. And so it's not easy to quit. It's not easy to deal with that strong physical and behavioral addiction. And one thing about when you're in a space that has a tobacco-free environment, a tobacco-free policy, just like Trina and Brian have mentioned, the agencies they represent, that tobacco-free environment not only protects people from exposure to secondhand smoke, it also supports long-term recovery from other substances. And there's a strong correlation between tobacco use and recovery from other substances. There's similar triggers that works on the similar chemicals in the neurotransmitters in the brain. So it supports sobriety and recovery overall. It eliminates exposure to secondhand smoke. And then it also, just in general, in the public, wherever you have, tobacco-free workplaces or tobacco-free public places, it supports those who are trying to quit. And so it's a very powerful public health tool, behavioral health tool. And as Brian mentioned, behavioral health facilities, they have the responsibility, just like other healthcare facilities, to provide a healthy and safe environment. And if you're committed to providing a healthy and safe environment that supports recovery, supports quitting, then tobacco use on your campus doesn't really have a place. However, we're going to help you. We're going to help you tackle this addiction and support you, approaching it with compassion. You have to approach it comprehensively with quit support, signage, communications, compassion. So
yeah, I can pick up on that in terms of that process of, it's a mindset as well, changing the way we think about quitting, right? We often talk in the clinical space that there's a grieving period for folks who are coming into treatment about not having their crutch or not having their drug to use to be able to deal with whatever feelings, emotions, trauma they've experienced that leads them to feeling shameful when they come in, and have, exhausted and burned bridges and lost family members and support. So turning the mindset that includes the tobacco use and using more positive words about, we're going to help you on your wellness journey, and we're going to help you to make positive decisions, or we're going to help you walk through this transformation of leaving a life that was not productive for you to a more productive life. It's a part of that process, and it actually is easy to bring the tobacco use disorder into the conversation once it becomes a part of your everyday process.
That's uplifting to hear, that it's easy once it becomes a part of your process. And I'm thinking of maybe the viewer or listener who might see it as a daunting task, and might try and kick that can down the road. Is there anything that through your experience or research or understanding that you could share to help inspire someone to take the first step?
So I will say we focus a lot on practicing the change of habit. It's even that sense of bringing hand to mouth for
Mhm.
someone who is addicted to tobacco products. By thinking of it holistically, and we have a benefit at Charlotte Rescue Mission of having folks in residential treatment for a lot longer than 28 days. Our
Mhm.
program is 4 months long initially. And so we have the time to be able to work with someone around changing the way they think about their patterns and about their practices. And so with that, individually, our counselors are working with folks around the change in the thought process. And we have the flexibility to do that. So 60 days into the program, we start actually seeing the results of talking through what a holistic transformation looks like. Whereas other programs at 60 days are being told they need to step someone down to outpatient or other programs. And so I think long-term treatment in a residential setting for us is what has definitely been a huge plus, that we have the flexibility to do that.
Reed, if I think about the challenge of your statement and question, Trina's outlined that when you make it part of your process, it's easy. So therefore, help find for the listener maybe the motivation or encouragement to take it on and to actually move from hearing that it's easy into doing the work, which is sort of a big barrier to overcome potentially. I think of a few things. One is, I'm speaking for me personally, I found early in our travels on this, personal incentive for me came from the idea of stories of many years of patients falling into one of three categories. Those who wanted to quit while they were here and couldn't do it, prior to us going tobacco free. Those that had quit prior to coming but resumed, and those that started smoking for the first time while in treatment. And for me personally, that was a huge incentive because of my clinical me, that when I hear any or all of those three things, there's my incentive. I'm like, okay, I'm gonna push through this and we're gonna get it done. But I think more than that, probably a ton of mental health, behavioral health, addiction treatment providers, SUD arena people already know how to go about it and can already position to do a great job. And maybe all they might need is some particular information or resources or things like that that pertain exactly to tobacco and nicotine and those related products. Point being, they have a ton of competency they're sitting on and might not have ever thought to connect it to addressing tobacco. And that their whole mindset, their values, their knowledge and methods are really well positioned. So then when you bring in things like tobacco specific information and clinical methods and all of the rest, it's the word easy really does fit. It really does.
I'd like to piggyback on that, we've referenced that there was a previous mindset or old paradigm that folks with behavioral health conditions can't quit or don't want to quit. What we know is that that's absolutely not true. They want to quit upwards of 70% plus just like the general population. And the other thing with this old paradigm that, oh, that's not supposed to be done in behavioral health facilities, let's put it in this box by itself. As we change that and we incorporate this into the addiction treatment process, the mental health treatment process, and provide training to these wonderful, uniquely qualified clinicians who already understand addiction and are already treating addiction. We just add in tobacco-specific information that has not yet really been included in those professional training programs, our schools of, of addiction counseling and social work and so forth. And that's another systems change we need to work on, that professional education. And so that's something that we have identified in public health, the role where we can really collaborate and connect behavioral health professionals with that training that's tobacco specific. And then the other thing I want to mention is that there is a standard of care for tobacco treatment, and that involves the combination of that counseling that addiction professionals already do, that problem solving and counseling, along with a combination of one or more of the FDA approved quit medications. And those medications are very, very important. One thing that we've worked to do with in our collaboration is to ensure behavioral health agencies have nicotine replacement therapy, or NRT, the nicotine patch, gum, lozenge on hand. So when someone shows up at your door and they find out, especially with residential programs, right? They find out that, oh, I can't smoke here or use my tobacco here. Well, we have a nicotine patch, and, to start educating on that medication-assisted treatment, MAT, that we hear in other substance use disorder treatment. Well, NRT is a medication-assisted treatment for tobacco use disorder. And just incorporating that into the professional training and education for those behavioral health counselors, as well as patients and families. There's just a lot of awareness that we can do that starts with normalizing tobacco treatment and normalizing this being included as that whole package, that wellness package. But and there are some just wonderful free and low cost training resources for professionals to learn about that standard of care for tobacco treatment.
Where can I find those?
Well, one thing in North Carolina, we have the Duke UNC TTS Tobacco Treatment Specialist Program, which is just an amazing program. It's a collaboration between Duke Smoking Cessation Center and UNC Chapel Hill Family Medicine and Division of Public Health. So I can I can provide a website. I mean, if you go to the Duke UNC TTS, if you Google Duke UNC TTS, you'll go to that. Plus, we have a Change for Life tobacco-free recovery webpage that Mecklenburg County Public Health houses, and we have information there. But that is a high-level training program that costs. There are other resources through, if you go to breatheasync.org, that is a website that North Carolina Public Health hosts. And there is a training page on the breatheasync.org website. There are free trainings that are being provided. There's also, there's modules online. So going to breatheasync.org is a good place to start, as well as folks could connect with me at kimberly.bayha@mecnc.gov. And I'll be glad to share resources, training resources. There's a ton of information online, and it's a matter of us just connecting folks to these resources.
I think another resource is others in the field, and
Yes.
say Trina and Kim here and me together knowing each other, and we're a resource to each other. And I've figured that out over the years of our tobacco-free implementation, that you can literally phone a friend, throw an email over, hold a brief meeting or what have you, that those doing this work I found are super willing to share. And those resources are sort of irreplaceable and indispensable. But what I mean is the collaborative nature of people doing this work that can say, well, we tried this, here's 3 or 4 things that really didn't go well,
Yeah.
lessons learned.
Yeah.
And here's a couple things that worked and we didn't really know that they would, but it turned out to teach us a lot, even as we were trying to do this, So I found most folks doing this tobacco-free effort are super collaborative. And I think there's also not a replacement for the lived experience of transforming and sustaining an organization from not tobacco-free to tobacco-free. To me, that's another giant resource that I've really benefited from over the years.
With a goal of trying to help other treatment centers, if they're going to treat addiction, Pavillon and Charlotte Rescue Mission are long-term treatments, which they're uniquely qualified and set up to do this work, but maybe a harder sell to someone who, where do we balance harm reduction with complete treatment?
I think one fear we had prior to doing it, and while we were starting to do it, was that our admissions would simply drop to 0, or something very close to 0, and that would be that. And it was a very significant worry that that's exactly what was going to happen, and it didn't matter what you knew or thought you could do, that this is uncontrollable. You can't control another person, in truth. And so then all the customers go away and that's it. So if we have clinical knowledge and willingness to help in the best ways, it wouldn't matter a bit, because you'll just, all the admissions will stop. And that was a huge concern. It turned out to be the other way around. And none of us thought it would be anything other than less. And it turned out to not only not be less, but it turned out to not be that way. And it turned out actually to be more. And I think another worry, once we made the change, we convinced ourselves, maybe through our experience, we had sort of a lived knowledge rather than just an intellectual knowledge. What the question was, what is addiction treatment that allows addiction to go on during the treatment? Like what is addiction treatment? And there's all kinds of levels and stages of ready, willing, and able. So I'm not framing anything other than tobacco free as having no value in helping people. I don't mean that at all. But what I do mean is, what are we going to do in truth, and how will it really go? And the change was so good that what we landed on might sound a little strange, and I hope it does. Wow, we're doing addiction treatment. That's what we did. We moved into doing what we were set up to do all along. And none of us anticipated coming to that realization or feeling congruent about behaving in alignment with our values. None of us thought that beforehand. It took months for that to settle into us. And that was a positive thing as well.
So we have the same fear at Charlotte Rescue Mission, and being a behavioral health provider in the community that is not tied to Medicaid or state funding, and living off of the generosity of our private donors and our business donors, if you will. That was a huge concern, is if our census drops and we have folks who are donating money, what are they donating for? And we did not experience that significant drop in census. Similar to what Brian is saying, our census maintained and has since increased. And we were making this transition right before COVID became, the number one topic we were all talking about in 2020. So 2020 and 2021. So that fear was there. And then on another end, almost a fear of success. Like, what if we do this and it works? Because we did have some staff members, and we still do have staff members who have not yet made that full transition to quitting smoking. We've had a number of staff members who quit and are walking the walk along with our residents. But there was a little bit of that underlying, like, what if we're right and this is the right thing to do, that those naysayers would have to kind of like, own up that this was the right thing to do and either get on board or make a different choice. So that kind of has been our journey.
How do you frame compassion? Has felt like a theme of our talk. How do we frame to the naysayer that, yes, this was the right thing to do, and our fears were not in our experience? How do we compassionately communicate that message to inspire, someone to come along with us rather than, let go or be dragged kind of mentality instead of a hand to pull up?
Well, it's tough to put it into words, I guess. We watch it every day when someone walks in the door, and we tell them, we're like, we're going to come alongside you in this journey, and we're going to guide you along, but ultimately you make the choices of where your journey takes you. At Charlotte Rescue Mission, we use the word transformation a lot. We are in the business of transformation. And because we bring spirituality and our Christian faith into the walk, we use that as well. So we, even our staff, we're very compassionate with them around looking at yourself in the mirror every day and doing the next right thing. And so we practice that every day, to where, again, the length of time that we have someone in our program is a huge benefit, because by day 60, we start to see a change in the way that they are holding their head up, and the way that they're communicating with their counselor, and the way they're participating in the groups, and they're starting to internalize the message.
Reed, if I think about your statement and challenge, what could be said to, I'm rephrasing it a little bit, what could be said to encourage or engender hope or optimism or something credible that was positive in making this change? I don't know if you intended it this way, but I loved the way you put it, because it was a little ambiguous to me whether you meant the patient who hasn't admitted yet, or if you meant the leader attempting to lead the change in their organization. I'll answer both. And I think I have the same answer for both. And I think the simple, honest answer is it's in people. Somebody such as Kim or Trina, who knows and has lived doing the work, can transmit that hope not effortlessly, but easily. They can easily transmit the hope by knowing and doing this for a long time. And you end up picking up that encouragement and confidence. It's not just intellectual, it's lived. And the one who's still hurting has many other hurts than just the results of tobacco, you know? And so to have somebody who's credible saying it gets better, come along, you know, is my first answer. And my second answer is the same. When we've been in meetings with other organizations who are getting ready to make the change, or in the middle of making the change, having other, say, administrative leaders, medical directors, clinical types, or whoever it is guiding change that have already done it for years, or also doing it, and you're not alone. And so there's folks that know and have lived the experience of guiding the change and impart that. And so the same is true there. I think it's in people and really helping each other. I don't know a better answer than that, or a more accurate one than that.
And I'll add a word that we use a lot is that it's a journey, and it truly is a journey. That it's a journey for the organization, for employees, their staff, for patients and families, and again approaching it with compassion. With we understand that this is hard. We understand this addiction. We have the tools and the resources and the compassion to walk with you on this journey, you know. And this is it's an employee health initiative. This is not, it's about patient care, patients getting well, but it's also about employee wellness and looking, and that organization looking internally at, do we provide a employee health plan that supports our staff in quitting? You know, what are the tools that we can provide to empower our patients and our staff? And just want to underline what both Trina and Brian have said about the lived experience of other organizations that have done this. That is so powerful, and we have just really seen that in our local coalition. As leaders have committed to this journey, and then they share and they pay it forward. That it's the right thing to do. And what's so exciting is that when you commit to going through this journey, you pull the pieces together, and you just persevere and you don't give up. What's on the other side is wellness. And that is so hopeful and positive, and that's what we're here for. And we've got to cut through all the noise that the tobacco industry and some of these old tapes that we have in our heads that are trying to prevent us from getting there. And we realize, we lock arms and realize, you know, going on this journey together, it's about wellness, and that's about people, as Brian said.
Yeah, Brian did.
I'm thinking about, you know, with public health perspective and a clinical perspective, with this journey towards wellness, people together, you know, where is the mutual relevance between these two fields? Where's the mutual support? And to the viewer, to the listener, everything that has been or will be mentioned as far as a resource or tangible action item during this talk is in the description. Scroll down through the description. You'll find what you need there. So yeah, mutual relevance, mutual support between public health and clinical mindsets. Where is it? How do we use it?
I've benefited greatly by being exposed to the tobacco-free group in North Carolina on many levels. All the levels Kim outlined of tobacco-free leadership in the state. I've been exposed to all of them, and the knowledge and experience has helped me tremendously. And if I tried, Reed, to encapsulate it in how that public health mindset has benefited me as a clinician, and it might be surprising to hear that somebody who's done addiction treatment now since '88 has taken a step back and looked at it and learned dispassionately by hearing someone in public health say to me something along the line of, it's great, you're doing great work. How are people doing? In other words, you can hear taking the very long view. And it's like, yikes, as an addiction treatment professional, maybe I should take on the whole problem over its whole duration rather than just say our services are sufficient when we overlook tobacco entirely and only think about the very, very short run. So I think the public health perspective has broadened my thinking and also made it more specific, broader in some ways and more specific in other ways. And that's brought me forward as an addiction counselor and addiction treatment professional in a huge way.
I'll add, to use a cliche that we've all heard, we often work in silos, and we know that's not going to get us where we need to go. Your health does not just happen at the doctor's office, at the hospital. Your health that's only maybe 20% or less. It happens in the community, in your environment, in your family, at your work. And we're also learning a lot more about health equity, health disparities, those conditions where people live, work, play, pray, that all. So we have to, so no one entity can do it alone. We're going to, the health of the community will improve if we collaborate. And I think in the past, we've, before I embarked on this work, I didn't know the whole language in the behavioral health world. I didn't have close relationships with any behavioral health professionals. But then once we intentionally said, hey, we have some common goals here, we started reaching out, building relationships. That's how things happen. And then I was like, oh my gosh, we have a very similar mission and we can help each other. And so public health is, we look at what we call population health, the health of the whole community. And it's not until you address some of those tobacco disparities or those health disparities in certain subpopulations, like in this case, the behavioral health populations. It's also that until you help the least of these, then that's how we all get better. That's how the whole community improves its health. And so how can we not work with each other? If we're truly going to do this, we have to work together, and we're all part of public health. So
there's a term that we often use in the clinical space that's it's called parallel process. And we often, as clinicians, will ask in our world, we call them residents, not clients, because they live with us. We will ask our residents to be open-minded about change. And so that same level of being open-minded was what we challenged our clinicians with having when we started the conversation about training and about gaining the information necessary to be able to share not only with themselves, but with our residents when we embarked on this journey. And so as I was listening to Brian and Kim talk, the parallel process just kept ringing in my head about, yes, that's exactly, we're asking our residents to do something that we need to be willing to do as well. And so that collaboration and that working together means we're open-minded, and we're willing to hear something different and move in a different direction. And when we do that, we are improving that population health.
And when we talk about tobacco control, we talk about secondhand smoke and thirdhand smoke, are we just talking about cigarettes and dip, or are we talking about nicotine in all of its forms? Are they treated differently? And then a third or fourth, I don't know how many questions I'm slamming into these prompts. When we talk about substitutes that we use clinically to help someone stop, like patches and gums and lozenge, you know, what's the plan for getting off of those?
Well, one thing that I'll start by saying that we're talking about all tobacco products, not just smoking cigarettes. And so in tobacco control, we talk about combustible tobacco products. It requires fire, cigarettes, pipes, hookah, cigarillos, and then non-combustible or smokeless, such as dip, chew, snuff. And then this emerging crazy huge field of vaping or electronic cigarettes. And then now we also have synthetic nicotine, because the industry is putting out new products because they don't want to lose money, right? These oral tobacco products that are made out of synthetic. And so in public health, we work diligently when we're working on health policy, making sure those definitions are spelled out, and legally in North Carolina, as well as with the FDA, tobacco products include all of the above: combustible, non-combustible, and synthetic nicotine. And so you can't just use a partial definition. It has to be that comprehensive definition of all tobacco products.
So similar to, if you're going to treat addiction,
Right.
If you're going to cease nicotine abuse or use, I don't know what's the most correct way to say it, then address the whole problem.
The literature's pretty clear on the effectiveness being best for the combination of approved medications, if you will, or medication supports, nicotine replacement therapies on the one hand, plus proper quit coaching on the other hand. And there are some factors that are specific to tobacco or nicotine in that that the average, even long career addiction treatment professional might not be specifically aware of. But it's important to know that both can and should be available together.
And then if you wanted to follow up on your question about tapering down, if you will, you know, we take full advantage of the North Carolina Quit Line and the guidance of the Quit Line counselors working with our residents when they make their phone call initially and talk to them about their use, and they send the prescription to our facility and they work with them, you know, specific to the patches and what comes in the mail for them. So, you know, we work with each person individually, of course, because it's going to be different, but we do rely on those other resources that we have available to us to support the counseling that is happening in our facility.
Awesome. So the NC Quit Line, some trainings for those that are helping treat substance use disorder, maybe some inspiration for individuals, people, not individuals, right, Brian? People who might have heard or watched and want to quit, and don't have a larger monkey on their back that might send them somewhere, like the Charlotte Rescue Mission or Pavillon, to use and reach out. Anything I'm missing? Is there a question I haven't asked that you wish I had? And if so, ask yourself an answer, because I want to hear it.
One thing that, thank you, Trina, for bringing up the North Carolina Quit Line, or Quit Line NC, we say. I just wanted to reiterate, and if you, Reed, could include this in the resources as you mentioned, anybody can access Quit Line NC by calling 1-800-QUIT-NOW, or you can go to quitlinenc.com, or you can text the word READY, READY, to the number 34191, 34191. So those are, we say you can talk, text, or type to connect to Quit Line NC. And it is an amazing service. It's available 24 hours a day, 7 days a week at no cost. And you are connected to a quit coach who is a counselor. And they do that initial intake call to really find out where you are, what your habit is, what you've used, what you've tried in the past. And they start to educate you on evidence-based tobacco treatment and come up with a personal plan, and then can mail to you to whatever address, be it at an agency or your home or a shelter, whatever address you provide, nicotine replacement therapy at no cost. Now, there are different protocols based on your needs, but one that's especially important to mention today, there's a behavioral health protocol. So if you're dealing with any type of mental health condition or substance use disorder, you can receive up to 12 weeks of free nicotine replacement therapy, along with 7 sessions of coaching. And so it really is a great resource. And for those behavioral health professionals who are listening, agencies can register to be a referral site and actually be put in a drop-down menu on the web portal, where you can, you want to bake that into, to use one of Brian's terms, bake that into your clinical processes, referring to the Quit Line, and the Quit Line proactively reaches out. So it's a real, and you can get outcomes reports. And so it's a really great service that agencies can use and clients. And so just can't say enough about that. That is a free available service here in our state. And 1-800-QUIT-NOW works anywhere in the country. And what happens is there's a soft transfer behind the scenes based on your phone number to the vendor that provides that service for your state. And those services can vary a little bit from state to state, depending on the public health funding. And so what I've mentioned today is Quit Line NC from North Carolina.
No, I think, Reed, the only, to leave things on a positive note is that it works. It works. And it only requires a desire to make the change. I've been in this field over 25 years or so, and I would not do anything differently. It is a challenge, but it's a challenge that I embrace and enjoy coming to work every day, working with folks who are looking for a better life. But it works. And, we're grateful that we made that conversion to being a tobacco-free campus. Campuses, because we're multiple campuses. And we're going to keep doing it. And again, as Brian mentioned, we are a resource for other agencies who reach out and want to get tips and hear about how we did it, or, have you tried this, or, can we talk it through? And we are absolutely available, and love participating in the conversations around how we can communicate and work together and maybe be better tomorrow than we were today.
I have one more thought, unless Brian, I don't want to jump in. Did you have anything? I just wanted to share that it's so important. I know there are folks who have tried to quit in the past and maybe weren't successful yet. And we hear that, oh, I've tried, the patch doesn't work, or I've tried to quit, I just can't. And one thing that we want you to know, that it takes practice in quitting. Every attempt is practice and takes you on further down that journey. There is no failure. You did not fail to quit. You were practicing. And so many folks are not provided that evidence-based treatment. And so, were you provided the right tools? And so, there it does work. There is hope. With the right tools and support, you can be tobacco free, and it can literally change your life. It can literally save your life. And just really applaud the behavioral health agencies that are supporting this effort. And when we say change for life, tobacco-free recovery, it's organization changing for life, in addition to those who are using, battling that addiction and changing for life.
Thank you, Kim and Trina and Brian, for joining me today for this Pavilloneers podcast. I think we did some wonderful exploration today. Hopefully provided some hope, healing, and lasting recovery to someone out there. So thank each of you for being a part of this, and look forward to being in touch with you soon.
Thank you.
Yeah,
Thank you so much.